Potential interest in any of the products mentioned. So, like Dr. Shalabh has just said that yes, medical management is just one part of the treatment. And as we know that endophthalmitis actually satisfies the criteria of an abscess, that is a closed cavity with purulent material. And any pus, if it is there in the body, it ideally should be drained. Therefore, vitrectomy helps by removal of the infecting organisms and the toxins. It provides adequate material for culture. It also removes the vitreous membranes, which may later on lead to tractional RD, and it also helps in the better distribution of antibiotics. So before the endophthalmitis vitrectomy study, there were divergent opinions regarding the role of vitrectomy in endophthalmitis, ranging from vitrectomy for all cases of endophthalmitis to vitrectomy for the very severe ones with worse visual acuity. And greater strides were made for post-cataract endophthalmitis with the execution of the prospective endophthalmitis vitrectomy study. So in this study, 420 patients were enrolled and they were divided into two groups. One group underwent vitrectomy with intravitreal antibiotics and the other group underwent a vitreous stab along with intravitreal antibiotics. And they were again further subdivided into two groups. One received systemic antibiotics and the other did not receive systemic antibiotics. The EVS concluded that if the visual acuity was more than hand movements, it did not make a difference in the outcome whether the patient underwent a vitreous stab with intravitreal antibiotic or underwent an immediate vitrectomy with intravitreal antibiotic. However, if the visual acuity was less than hand movements, immediate vitrectomy with intravitreal antibiotic was beneficial. And in their study, systemic antibiotics made no difference. So as we know that EVS gave us the first insights into the management of endophthalmitis. However, it had pitfalls because the results of endophthalmitis vitrectomy study could be applied only to post-cataract patients. And it excluded post-operative endophthalmitis patients from any other procedure other than cataract patients. So its criteria of visual acuity of less than hand movements undergoing vitrectomy could not be applied to other endophthalmitis cases, wherein early vitrectomy within 24 hours to 36 hours is very important. So these are bleb-related endophthalmitis, traumatic endophthalmitis, chronic post-operative endophthalmitis caused by fungus or by Propionibacterium acne, and endogenous endophthalmitis. So as we know that Propionibacterium acne, the organism resides in the capsular bag, and therefore pars plana vitrectomy with a central capsulectomy together with intravitreal antibiotics is the mainstay of treatment. Again, in fungus, the fungal infections, they cause persistent and recurrent inflammations, and therefore a complete vitrectomy with intravitreal voriconazole is recommended, and most of the time just the medical management may not suffice. Again, in bleb-related endophthalmitis, the organism is very virulent. It is caused by streptococci and Haemophilus influenzae. And these organisms liberate potent toxins and tissue-damaging enzymes which are responsible for the virulence and inflammation. And even if the intraocular spaces are sterilized with appropriate antibiotics, a significant amount of bacterial debris and potentially toxic products remain to account for treatment failure. Therefore, a primary vitrectomy with intravitreal antibiotics should be considered as the first line of management in bleb-associated endophthalmitis. Busby et al. In their series of 68 patients found that those who underwent pars plana vitrectomy had a greater likelihood of retaining a vision of 20 by 100 when compared to patients who just underwent a medical treatment. Again, in post-traumatic endophthalmitis, the prognosis is poor because of polymicrobial infection is implicated, of which Bacillus cereus is the most common, and it causes progressive infection. Again, it can be associated with intraocular foreign body and retinal detachment, and therefore early vitrectomy in traumatic endophthalmitis is recommended. Endogenous endophthalmitis seen in immunocompromised patients like in HIV, chronic alcoholics, diabetics. Again, vitrectomy is useful in the posterior diffuse type, and however, despite aggressive treatment, the outcome is poor. A study from Singapore over a 4-year period showed that 17 of 32 patients developed no perception of light even after early surgical intervention. Therefore, in these cases, just medical management will not be helpful, and waiting for a visual acuity to go below hand movements cannot be done. Then how much of vitrectomy should be done? According to the endophthalmitis vitrectomy study, only core vitrectomy, that is removal of the central and anterior vitrectomy, should be done. The central and the anterior part of the vitreous should be removed, and PVD induction should be avoided. However, a study by Ginny Giampolo et al., the complete and early vitrectomy for endophthalmitis, advocated induction of PVD and a little more aggressive vitrectomy. According to the authors, induction of PVD should be done only at the posterior pole over the non-necrotic area and should not extend beyond the equator. And the posterior exudates over the surface of the retina can be aspirated by soft-tip flute needle. This is important because when the patient lies down, these posterior exudates form a macular hypopyon, and this results in macular degeneration. Silicone oil can also be injected in cases where there is an inadvertent retinal break during vitrectomy or there is an associated retinal detachment. Also in recurrent fungal infections, silicone oil can be used because it has anti-infective properties. After this, if intravitreal injection has to be injected, it should be remembered that the dose should be reduced to half as the oil prolongs the half-life of these antibiotics. Each surgical procedure has its disadvantage, and therefore vitrectomy also it can cause a retinal break. A retinal break can occur as a result of a normal complication. It can occur because of direct injury with the instrument, because of aggressive vitrectomy to induce PVD. The retina in endophthalmitis is friable and necrotic, and it can lead to retinal detachment, vitreous hemorrhage. There can be retinal toxicity due to the intravitreal antibiotics used. Some people even now use aminoglycosides like amikacin, which can lead to macular infarction. It can also cause phthisis bulbi. So I'll just show a video wherein PVD induction has been done. Although EVS does not recommend this, but so this is a video where first the core vitrectomy is done, that is the central and anterior vitreous is removed. Although the strongest view against doing PVD induction is that it can cause a retinal break, and one must remember that the extent of vitrectomy should be decided on the type of case. It should not be done for all cases, and the surgeon should actually decide it from. They should decide it from which case it has to be done and which should not be done. It should be remembered that only the central part, the central vitreous should be, the central part, like over here, the central part, we are inducing the PVD. Yes, as you can see here, the PVD has been induced. The media has now cleared much better, and these are the posterior exudates I was talking about, because these should be removed, because when the patient lies down, it forms a macular hypopyon, a hypopyon near the macula, and this ultimately leads to macular degeneration. So 20 years after the endophthalmitis vitrectomy study, we know that the results of EVS cannot be used for all types of endophthalmitis. The EVS excluded eyes with no perception of light and severe anterior chamber opacification from their study, which may have actually improved with early vitrectomy. While the EVS recommended intravitreal antibiotics as their weapon, and 53% of their patients achieved a visual acuity of 20/40. Study by Giampolo, that is the complete and early vitrectomy for endophthalmitis, showed that 91% of their cases achieved a visual acuity of 20/40 by undergoing early vitrectomy within 24 hours. So post-operative endophthalmitis is not going to disappear, rather it is increasing because of clear corneal cataract surgeries. Two most important factors in improving prognosis are selecting the clinical appearance of the case and course to primarily determine therapy and not the visual acuity. Technological advancements in vitreoretinal surgery since EVS have minimized the risks associated with vitrectomy, favoring initial use of vitrectomy even in less severe cases. Therefore, perform early and complete vitrectomy. As Celsus stated 2 millenniums ago, UB pus, AB evacua, which means that if there is pus, it should be evacuated. His words could not be truer today. Thank you.
Thank you, Dr. Deepak. Thank you very much.